We're walking through what happens the moment a stroke alert hits the emergency department. If EMS has done their part, they've called ahead with a suspected stroke. That gives the hospital just enough time to get the stroke team in place. Emergency physician, neurology, radiology lab, ICU, and the nurses who are about to run this patient through every protocol we've got. The clock is ticking. The goal is to get from arrival to TPA administration in under 45 minutes. Every second counts. The very first step is imaging. A non-contrast CT scan has to happen within the first 25 minutes of arrival. We need to rule out a bleed. You cannot give TPA if the stroke is hemorrhagic. If there's no blood, we look for signs of early ischemia, like loss of gray-white differentiation or a dense middle cerebral artery sign. Based on what we find, we might add a CT angiogram or perfusion scan, especially if we're considering thrombectomy. Now, TPA. Not every patient qualifies. So here's what we check. They must be at least 18. The stroke has to be ischemic, and symptom onset must be less than 4.5 hours ago, ideally under 3. Systolic BP needs to be 185 or lower, diastolic 110 or lower. INR must be 1.7 or less if they're on anticoagulants. Platelet count has to be over 100,000. No recent stroke, brain surgery, GI bleeding, or signs of infective endocarditis. We're also scoring them using the NIH Stroke Scale, which helps quantify the severity. It runs from 0 to 42. The higher the score, the more severe the stroke. A score of 6 or more also puts them on the radar for possible endovascular intervention. If they meet the criteria, we dose TPA based on weight. It's 0.9 milligrams per kilogram, maxing out at 90 milligrams. 10% of that goes in fast as a 1-minute IV push. The rest goes in over an hour with a pump. You'll need 2 IV sites, one for the TPA, one for anything else. After that, we don't touch them with any anticoagulants or antiplatelet meds for 24 hours. That includes aspirin. We also hold off on inserting any tubes unless absolutely necessary. That means no Foley, no NGT, no central lines unless it's life-saving. Neurochecks and vital signs are non-negotiable. Every 15 minutes for the first 2 hours, then every 30 minutes for 6 hours, then hourly until we hit the 24-hour mark. Now let's talk endovascular therapy, the rescue option when TPA isn't enough or can't be used. Patients qualify if they've got a large vessel occlusion, like the internal carotid or proximal middle cerebral artery. They also need to meet all of the following: NIH Stroke Scale score of at least 6, aspect score of 6 or greater on their initial CT. Groin puncture can be started within 6 hours of symptom onset. No significant disability prior to stroke, age 18 or older. In some cases, we can go up to 24 hours post-onset if perfusion imaging shows viable tissue. This isn't something every hospital can do. You need a certified stroke center with an interventional neuroradiologist or stroke-trained vascular team. And you still give TPA if they qualify. Don't delay it just because you're considering thrombectomy. This entire process is about speed, coordination, and making sure we don't miss a window. Stroke kills brain cells by the second, and it's our job to act before the damage is done.